Done. Uh, Good evening, everyone. Myself, Dr. Praful Rakholiya, consultant gastroenterologist at Gujarat Hospital, Gastro and Vascular Center. I welcome all in behalf of Gujarat Hospital to attend today's seminar on portal hypertension and variceal bleeding. Today we'll discuss regarding portal hypertension and variceal bleeding. Portal hypertension. It is defined as increase in hepatic venous pressure gradient to 6 mmHg or greater. And this hepatic venous pressure gradient is the difference between raised hepatic venous pressure and free hepatic venous pressure. The another terminology is clinically significant portal hypertension, which is defined as HVPG more than 10 mmHg. Why it is called clinically significant? Because at HVPG more than 10 mmHg, there is increased risk of varices development. So it is clinically significant portal hypertension when HVPG is more than 10 mmHg. First, we will discuss about the portal circulation and anatomy. Portal vein is formed by splenic mainly by splenic vein and superior mesenteric vein, which forms portal vein, and then it divides into right and left portal vein. Then there are tributaries, and which is last one is the portal venule, which drain into the sinusoid, and then it drains into the central vein, which forms three major hepatic veins, left, right, and middle, and drain into the inferior vena cava. So when there is a problem in this circuit, when there is a damage to the hepatocytes, or when there is activation of copper cells and formation of fibrosis, it will lead to compression of this sinusoids and portal vein, and it increases the pressure in the liver, which increase pressure in the portal vein. So this is the anatomy of hepatic microvasculature. This is the sinusoid. This is a normal one in which there is a fenestration, and from here fluids goes into the perihepatic space or space of Descept. Here there are hepatic stellate cells which get activated in case of liver injury and produces which which is which produces collagens and which get deposited in the space of D cell, and it increases the resistance over sinusoid, and thus it leads to increased pressure to the portal system. There are various causes and classification of portal hypertension, and this is a classification of causes of portal hypertension. It is divided into three causes: post-hepatic, intrahepatic, and prehepatic causes. And this intrahepatic is divided into pre-sinusoidal, sinusoidal, and post-sinusoidal causes. From this, there are few causes which are more common, like cirrhosis, schistosomiasis, extrahepatic portal vein thrombosis, idiopathic portal hypertension, and cardiac fibrosis. Others are less common, like fibrocystic liver disease, nodular regenerative hyperplasia, sarcoidosis, malignancy. And this portal hypertension leads to three more common complications like ascites, varices, which are esophageal gastric varices, rectal varices, and sometimes leads to portal caput medusae, and also it causes splenomegaly. How we will measure this portal pressure? So we can measure portal pressure by four measures. We can measure hepatic vein pressure gradient via transjugular way. Other, which is indirectly, we can measure this pressure, and directly we can measure by splenic pulse pressure and portal vein pressure. And one more indices is the endoscopic variceal pressure measurement. Most commonly used is the hepatic vein pressure gradient, but nowadays we are not using because it is invasive. What is the prognostic value of this HVPG? Normally is 1 to 5 mmHg. 6 to 10 is called as a portal hypertension, but mild. If it is 10 or more, then it leads to clinical significant portal hypertension, which indicates there is development of varices. If HVPG is more than 12 mmHg, then there is increased risk of variceal bleeding or rupture of varices. If it is more than or equal to 16 or mmHg, then there is increased risk of mortality related to this variceal bleeding. And if the HVPG is more than or equal to 20 mmHg, then there is increased risk of failure of endoscopic and medical therapy, and there is increased risk of mortality also. Once HVPG portal hypertension is 6 to 10 mmHg, in compensated cirrhosis, it leads to mild PEH or clinically significant portal hypertension. And when there is HVPG is more than 10 mmHg, there will be increased hemodynamic circulation, which leads to development of variceal hemorrhage because of increased circulation, hemodynamic circulation. And also there is development of ascites and hepatic encephalopathy, which leads to decompensation of cirrhosis. How we can detect this varices? So we can detect it by endoscopy, by ultrasound, CT scan, MRI, or endoscopic ultrasound. By endoscopy, we can grade this esophageal varices into three grades. Like if varices are small and straight, we can grade it as a 1. If varices is tortuous and it occupies less than 1/3 of the esophageal lumen, then it is grade 2. And varices which is large and occupying more than 1/3 of esophageal lumen, it is called grade 3. We can also grade it as like small varices and large varices. Small varices is 5 mm or less in diameter. Large is a 5 mm, more than 5 mm diameter of varices. So these are the dilated esophageal veins. This is grade 2 varices, and this is esophageal varices with a fibrin plug on the top of this varices. It indicates there was a recent bleeding in the psoriasis. These are the gastric varices. Gastric varices are classified by Sarin. It was classified in a 4 group, like gastroesophageal varices grade 1, in which esophageal varices is in continuous with gastric varices. GOV2, in which esophageal varices is continuous with gastric varices in fundus or cardia, while other two are isolated gastric varices, in which type 1 is in which isolated gastric varices present in the fundus, and type 2 gastric varices are present elsewhere in the body or antrum of the stomach. Recently, AZA guideline has classified gastric varices into 3 groups. IGV1 and GOV2 is classified as a cardiofundal gastric varices because they are present in the cardiac and fundus. The GOV1 was classified as a lesser curve varices because this varices is directly continuously present in the lesser curvature, while IGV2 is classified as a distal gastric varices as these varices are present elsewhere in the body and antrum of the stomach. By CT scan, we can see these are the dilated varices around the esophagus, and there is a dilated portal vein and splenic vein. Once varices is diagnosed, then we will, if there are no varices, then we will repeat endoscopy every 2 to 3 years. And if large varices, then we have to manage it. And if there are small varices, then we can repeat endoscopy every 1 or 2 years according to the ongoing underlying etiology for the liver disease. Treatment of portal hypertension, it mainly the aims are is reducing portal blood flow. How we can reduce this blood flow? By pharmacological agents like beta blocker, which reduces the cardiac output and thus it reduces portal flow. Or we can use the vasopressor, which is directly splanchnic vasoconstriction dilatation. It causes splanchnic vasoconstriction and reduces the hepatic portal blood flow. Or other is by decreasing intrahepatic resistance, which is we can do by pharmacological agents like carvedilol, which has a alpha blocking activity and causes dilatation of sinusoid, and thus it decreases the hepatic resistance. And other is the photosystemic shunt, like surgical. It may be either radiological like tips or surgical creation of this shunt. Now we'll move on variceal bleeding. So once a patient has esophageal varices, is diagnosed with esophageal varices, then we can do either a screening or we can start primary prophylaxis, or we can manage acute variceal bleeding and then we can start on secondary prophylaxis. So what are the risk factors for development of variceal bleeding? One is already we discussed HVPG more than 12 mm Hg, there is increased risk of rupture of varices. In large esophageal varices, CTP grade class C and presence of TAN society. These are the 4 risk factors which can increase the risk of variceal bleeding. What will be the presentation? Patient will present with hematemesis, with or without melena. If patient is having melena also, then we can say that patient had a very massive hematemesis, and it will be painless. What will be the first line treatment in variceal bleeding? So first is ABC, airway, breathing and circulation. So first priority will be airway maintenance, because there is increased risk of aspiration because of ongoing bleeding. And second priority will be circulation. So patient will be hemodynamically unstable due to massive hematemesis. So we have to resuscitate the patient, and if required, we have to do blood transfusion. So in patient who present with acute variceal bleeding, the first line management is first we have to stabilize the patient hemodynamically. For that, we have to do these four things. One is resuscitation. Second is vasoactive agent. We have to start antibiotics, and if required, we have to transfuse blood. So for resuscitation, first we have to assess the volume status of patient. That we can assess by heart rate, pulse volume, blood pressure, or if patient is having postural hypotension or postural symptoms, and urine output and JVP. So first we will start IV fluids. The initial IV fluid will be normal saline, and if patient's prothrombin time is more than 5 seconds, then we can transfuse fresh frozen plasma also. But we have to avoid over transfusion, because there will be increased risk of increase in portal pressure, and then that may increase variceal pressure and increase variceal bleeding. That will not help in reducing variceal bleeding also. Second is pharmacological therapy. What will be the aim for pharmacological therapy? So this pharmacological agents will reduce splanchnic blood flow, so there will be decrease in portal pressure, and which we can do by starting somatostatin analogs or by vasopressin analogs. So somatostatin and its analog. Somatostatin is hypothalamic hormone which inhibits secretion of vasodilatory peptides from GI tract, and thus it decreases the splanchnic vasodilatation. But its short half-life is 2 minutes. So we have a synthetic analog octreotide which directly acts on splanchnic system, and it causes vasoconstriction. Its half-life is 1.5 hours and has excellent safety profile. It is given in a dose of 100 microgram IV state followed by 50 microgram per hour infusion. It is continued until patient is having mostly it can be transfused up to 5 days, or until patient's stool is clear, it's not malignant. Or we can start vasopressin and its analog. Vasopressin has the generalized vascular vasoconstriction effect, and half-life is short and required continuous infusion. So we are not using that. Apart from that, it has a side effect, means it causes renal failure also because of generalized vasoconstriction. So there is a synthetic analog of vasopressin is the terlipressin, which has a specific effect on splanchnic system, which causes splanchnic vasoconstriction only. Thus, it reduces the portal pressure. And its half-life is also long. It is given by a bolus form. It is advised as 1 milligram IV 6 to 8 hourly. But it has also few serious side effects like cardiac ischemia, GI ischemia, hyponatremia, and sometimes acute renal failure. Third, we have to start antibiotic, because in patient with GI bleed, there is increased risk of secondary infection to the patient, and also it may lead to spontaneous bacterial peritonitis. So once patient is having GI bleed, we must start antibiotic like third generation cephalosporin or fluoroquinolones. Fourth is the blood transfusion. We have to maintain blood volume also. We have to keep the target hemoglobin level of more than 7 grams. So if patient's hemoglobin is less than 7, then we should transfuse, and if it is more than 7, then we can just monitor with IV fluids and other pharmacological therapy. Then endoscoping. Once we have stabilized the patient with all those four measures like resuscitation, vasoactive agents, therapy, antibiotic, or if needed blood transfusion. Once patient is stabilized and hemodynamically stable, then only we have to do endoscopy to determine the cause of bleeding and also to prevent further bleeding if there is active bleeding. And once we have diagnosed esophageal varices, then we can do endoscopic intervention also if there is ongoing bleeding. We can do endoscopic variceal ligation. This is the band we will suck this varices, and then we will apply blend. So this blend will catch up this vessel, and then it causes thrombosis in this vessel, and then it slough off up within a week. But we have to monitor patient, and we have to do endoscopy after 2 weeks or after 4 weeks, and look for ulcer bleed at the EVL site. This is the esophageal varices, and there is active spotting from the variceal site, and band was applied, and now after applying the band, bleeding has stopped. The other measure we can do is endoscopic variceal sclerotherapy. This is done when we fail to localize the source of bleeding from the esophageal varices. Or also we can do is glue injection. We inject N-butyl cyanoacryl in the varix. Mostly we are using glue injection in the gastric varix. And also we can do EUS guided glue or coiling injection in the big gastric varices. If we are not able to stop bleeding with endoscopic measure, then we can, or we don't have a setup of endoscopy, then we can do a tamponade. In that we can put either Sangstaken Blackmore tube or Minnesota tube or Lincoln necklace tube. But most commonly we are using the Sangstaken Blackmore tube, in which we have to intubate the patient before putting this tube. And this tube we can put for up to 24 hours. The other measure is the self-expanding metal stent, that is the SX Dennis stent, that we can put at the site of active bleeding, and we can keep the stent for 2 weeks. There is an excellent response with this with this stent. If we are not able to stop bleeding with endoscopic therapy, then we can go for either rescue tips or early or preemptive tips. If after 2 sessions of endoscopic therapy, if still bleeding is continued, then we can go for rescue tips. And if a patient after first endoscopic therapy bleeding is stopped, but if patient has child class B and there was active bleeding, or patient with child class C with a score less than 40, in that case we can do early or preemptive tips to prevent recurrence of bleeding or failure of endoscopic therapy. So in tips, what we will do is we will reduce the portal pressure without an operation. And means we'll put a stent in the liver parenchyma through liver parenchyma, which will connect right portal vein and right hepatic vein. So it will decompress the portal pressure, and it directly blood will directly go to the right hepatic vein and into the IVC. But there will be complications while doing these tips. The most common are perforation of liver capsule. Then there is a chance of stenosis or occlusion or thrombosis of a stent, which is more common. It occurs in 50% of cases by 1 year. And there is also increased risk of hepatic encephalopathy. It's about 25% risk of development of hepatic encephalopathy post-tips. The other measure is we can do a balloon occluded retrograde transvenous obliteration of varices. This one we can do when we have done CT scan and we found that there are large splenorenal shunts. In that case, we can occlude gastric varices by this DRTO method. Last measure is the surgical therapy, in which we can do either non-shunt procedure. These are done when there is no veins are available for the shunting, like in case of portal and splenic vein thrombosis. in which case we can do either esophageal transection or we can do devascularization procedures. Other is a portosystemic shunts. Nowadays, non-shunt procedures we are not doing. Other is a portosystemic shunts, which are three to four types. One is a selective shunts. Second is a partial portosystemic shunts. Third is a portocaval shunts, in which there will be a side-to-side or end-to-end anastomosis between portal vein and inferior vena cava. But side-to-side anastomosis is more commonly used. And fourth is a mesenteric left portal venous bypass, which is mostly used in EHPEO. And in selective shunts, there are two types. One is a distal splenorenal shunt and other is a proximal splenorenal shunt. The most commonly used shunt is a distal splenorenal shunt, in which the splenic vein is cut from the distal end of the splenic vein from the spleen, and which is anastomosed with left renal vein. So it will drain only the splenic it will only drains esophageal varices and short gastric vein, but the flow from the blood will go into the IVC into the superior vena cava, so it will not reduce the portal pressure. So there is in this case there is an increased risk of development of ascites. Means it will not prevent development of ascites, but it reduces development of esophageal varices. So these are the algorithms of management of esophageal varices, in which first we have to do these four things like resuscitation, we start vasoactive agents, antibiotic and transfusion to keep hematocrit value up to 24%. Then we'll do endoscopy and see if there is esophageal varices are present, then we'll do ligation or sclerotherapy. And if bleeding is controlled, then we'll check for the child class and see if patient is having child class B or C, or MEL score is more than 18, or there was a requirement of blood transfusion of more than 4 units. Then we can go for early tips or preemptive tips. And if these are not there, if patient is having the child class A or MEL score is less than 18, then in that case we can start secondary prophylaxis after endoscopic therapy. And if bleeding is not controlled, then we'll do second endoscopic therapy within 24 hours. And if bleeding is controlled, then we will start secondary prophylaxis, or if bleeding is not controlled even after 2 endoscopic therapy, then we will keep patient or we'll do a balloon tamponade so that we can proceed for tips. This is from Schlesinger. Miss actively. Yes. Child B or C with active bleeding, when we went and we have done endoscopy, and if there was ongoing bleeding, if, yes. So in that case we can. No. But when we have done endoscopy, at that time, if there is active ongoing bleeding, if there is a spotting of varices, in that case, if child class B and C is there, then we can go for tips. If at the time of doing endoscopy, there was active bleeding ongoing. Then if this criteria are not there, if these 4 criteria are not there, then we can start secondary prophylaxis. If this criteria are present, if patient is having ongoing it, this one.
With 4 units of blood. If yes, then
child there.
Or weight is less than 80. Or transfusion requirement is less than 4. Then you go for
secondary profile.
Otherwise, you directly go for tips.
Preemptive, we can go for preemptive tips.
You can go. You say that does it mean that you can't run this patient from child B, child A, first of all, cognitive etiology. Second, suppose can you go for a serial endoscopy? What are the criteria for early tips? It is single building episode. The first building episode present there. You don't know the etiology. Okay, you go in the emergency room, you do the control of bleeding varices. You calculate the child B or C. If that is more than 80, you directly go for tips. Even if bleeding is controlled, that's why my question is.
Means it can be done within 72 hours. So we'll do workup by that time, and then we can go for early or preemptive tips.
Suppose this patient comes from alcohol and just for my knowledge, because most of the patients, you see the data, around 35% of the patients with child B and C presented with the GAB, 20% difference. It's a significant amount. And out of 10 presentation of child B or C, 3 present with the GAB. And by for clinical, most of the health grade score is more than 80 when they present it. Even after bleed, within 72 hours, there is weak of consent because of bleed. So they may for further worsen. They are not going to respond within 48 hours. Okay. And if it is there, okay, then you directly go for early treatment. I personally feel this is too aggressive. Because in many patients, support patient is alcoholic cirrhosis and presented for the first time. You have go for the evidence of alcohol, good nutrition control. Child C may convert to
B or A.
secondary episode may not occur. Means we used to see it in daily basis. The tips requirement for bleeding per se is a very unusual. What is the current indication for practical indication? Practical indication when there is acute bleeding is going on. Recurrent bleeding. First endoscopic temporary hemostasis ensured. Within 24 hours, second bleeding occurs. Hemostasis ensured. Within 24 hours, 48 hours, third bleeding occurs. Okay. Then you can go for it. So remember, the first bleeding, you are not able to control the bleed. Just put a vesica stand and work up for the bleeds. For ascites, it is a refractory ascites. For a recalcitrant ascites, provided patient side effect is good. Okay, but then
CTP less than 9 or
so no NC and nail score should be better.
Yeah, less than 80 it should be.
So usually the criteria is less than 12 like for
tips.
Okay, 12 to 18 results are right. And more than 18
is not contraindicated. No.
So good creatinine is also required to go for the tips. So where is the recommendation of tips?
And recurrent hepatic hydrothorax.
But this is the practical indication. So if this guideline must be changed because I know that it is too aggressive. Nobody is going to bleeding. If bleeding is controlled, the first episode and directly go for this. Suppose the patient has no bleeding, only the first syndrome, obstructive in the upper part.
And in the dips we can do.
The second you discussed about the HPV. In this clinical scenario, we used to measure the HPV. Because this HPV definition like this, but HPV is irrelevant. Okay. So in this clinical scenario, you go for the active HPV 11 for the portal hypertension.
If we are planning for tips, in that case, we can measure. No, that is for research. But in research, not research, clinical.
Suppose some patient comes to you, okay, and now you have seen there are three, four models. HPG measurement are used to be 95 models. Dr. Pratap used to say, okay, so that was for research purpose. So what are the practical needs? We used to do it particularly in a COD viewer when there is FCC, rejectable FCC, and you see child status. Okay, and before rejection we used to measure the HPG. Okay, if HPG is high, usually we say don't go for it. Usually it comes. Okay, that's what practically I have seen the usefulness of it. Now let us use HPG also. We are using other criteria. Count and you want to have a photo of the you go on how do you reason for the रिपीटेड स्टेटस पर नक्की करेंगे चाइल्ड स्टेटस जो ए होती है and we remove minimum maximum 3 segments. Child B not more than 1 segment. Child C no restriction. Child A we can remove maximum 3 segment surgically. Child B should only 1 segment, not more than 1 segment. Child C no.
But I think child criteria is relatively a crude criteria. Compared to the male, it is not a continuous score. Otherwise, apart from the, because if you see the criteria for rejection, palliative care or a transplant, it depends on the HPPG also, apart from the child stress.
Practically in any institution now, HPPG for
even in Medalist we used to do at that time.
But for resuscitation, I don't know.
In ILBS, they are doing this for research purpose, most of it.
So what I mean is, nowadays providing more and more
Now, another thing, there is a new probe is coming in market. You can do it EUSY. Via EUS, you can measure the HPPG and portal pressure. Okay, but whenever I used to read it, this HPPG, just I want to see where clinically we can apply. So suppose this drug is effective or not, that we can don't measure usually.
Chances of bleeding is there, and we are trialing whether in this patient we should go for therapeutic application, means by glue or what, because if HPPG is higher, then chances of bleeding is higher. In that case, we can go, but it is not absolutely criteria. But in case of doubt or hemoglobin is falling, and we have doubt that in this case we should go for therapeutic purpose or what, or that we can take dilemma and we can check for the HPPG. It is higher than chances of bleeding or bleeding is higher. So in that we can go for tips, because the chances of EVL, if the patient has more HPPG, the chances of therapeutic procedure failure is higher. So in that case, we can directly ask patient to go for tips, because in this endoscopic procedure will fail.
You see, basically before tips they used to measure HPPG.
If HPPG is more than 20, then that means risk of failure of EVL is more.
Giving another criteria of tips is also
what my point you understand? You have control of the bleeding, then you are going to measure HPPG. Now in how many patients? Once you control the bleed and you ask them to go for HPPG, if your HPPG is more than 20, we are going to go for tips. It is very unlikely. You are not going to do that. Okay. That's what I'm asking.
it is limiting factor. That's why
it is invasiveness. It is an invasive. It is practically invasive thing. So for measurement, it should be proceed for tips or not. It is, I think, not a group. But before tips, they used to measure HPPG, and after tips, they again measure the HPPG. So if HPPG is significantly reduced, okay, then tips are successful.
another thing is to check the after this, the chances of narrowing, as Dr. Praful mentioned, that 50% chances that it will reduce, and chances of hepatic encephalopathy is also there. So to see whether we have enlarged or dilated dilatation of the stent required or not, in that case also we can check HPG, because if we dilate
What I
more,
am telling differently, during the first attempt, maybe, I don't know because international radiologist is not here. Okay. From the HVPG, you may select a diameter of stent.
we can
Suppose for stent surgery. Uh, so from the portal pressure, suppose is there any cutoff? If portal pressure is like that, then we have to put a shunt diameter of this, or if it is that, then we have to put a shunt diameter from there.
We use it just for the efficacy of our shunt. We expect the at least 30% oil portion should be there after doing shunt. But that is for EHP. But as an addition, there is also the
stand.
You in EHP, it doesn't matter. The diameter is little bit larger. Okay, but in cirrhotic, it does matter because hepatic encephalopathy, that's why this chance is up to 25%. That's why this chance is up to 25%.
in zero shunt, generally we prefer the diameter 8 or so because then the dilation is called it's a dilation, but that is 8 mm diameter. It should not be more than 8 mm. We don't measure the
Okay, you put just put 8.
8 or 10
If
maximum.
water pressure is not decreasing, then we have to do dilatation of the stent. That should also be dilated because if we can more earlier reduction, chances of precipitation of hepatic encephalopathy will be there. So for that, actually this is important because after dilatation, how much
But it is in the same setting. You understand? You put a stent, you see the HVPG. If it is not reducing, there is something is abnormal. Okay, then either you dilate a stent, you see the patency of the stent, you see the position of the stent. That is altogether different story. Okay, but Ankit is not there. But this may be the one utility from the HVPG. How much pressure is there, and how you want to reduce? You may select the.
When we see portal pressure, if there is no follow fatigue, but there is anything, there may be something twist or innovation, some problem with that shunt.
Yeah. So
therapeutic efficacy, basically in short, whether we did apply that therapy, that is effective or not.
but at that time, what happens? You are already inside.
In
Okay, you go there.
Also, sir, in follow-up also, if patient came with the re-bleed, then we can check for that HVPG. If still high, then we can dilate stent. If that fails, we can put stent in stent. So this
But
can be
there must be reason why you have to put a stent in stent. You can't put a 10 millimeter stent inside 8 millimeter stent. It remain 8 millimeter. Understand? If it is fully open, there must be some narrowing of stent thrombosis or some practical issues are there. So before going to HVPG, you just go for the CT venography or MR venography. You see the stent. You see is there any thrombosis or not? Is there any narrowing or not? And if it is there, then you go inside. And that is the same process just like doing the tips. So, but as per my knowledge, means apart from the tips, HVPG usually before hepatic resection in few institute till there, and they will give you two one post-op development of ascites also, and second post-operative chances of bleed. Decompensate in form of they cannot judge the bilirubin, but mainly ascites. So particularly
Exclusion test also.
in case of
but that gives you a overall functional capacity of liver.
In case of dilemma, patient with HCC, CTPA, and if we are going for resection, for that also we can do HVPG. That patient is hypertension.
That's what I am telling. If HVPG is good, if it is a resectable, a child is cirrhotic, then go for it. But if HVPG is bad, then you have a child is cirrhotic and you go for resection, chances of decompensation is much more. So usually what I have seen in few cases, they used to measure HVPG in these cases. આ મને ને લેગ આવે છે આ લોકો બોલે ને પછી મને 2 સેકન્ડ પછી એટલે પેલું એટલે ભલે હું આમ બોલું આમ છું કન્ટિન્યુ અચ્છા તારે
So this is algorithm for acute bleeding from management of acute bleeding from gastric varices. In that also we'll measure first 4 steps, and then if endoscopic therapy is possible, we'll do, and if bleeding is controlled, then we may, if we have availability of cyanoacrylate, then we can do a glue therapy. And if not available, then we'll go for tips. And if endoscopic therapy is also not possible, then we can directly go for tips. Or bleeding if not controlled, then also we can go for tips. This was the management of acute bleeding of varices, and what we have to do after control of the bleeding. Once bleeding is controlled, we can start patient on secondary prophylaxis, that is on beta adrenergic blocking agent, and plus we'll do endoscopic variceal ligation every 4 weekly until the varices are obliterated. And if patient we have started beta blocking agents and previously EVL was done, and if patient present with recurrent bleeding, then in that case, if we'll see whether patient was adherent to pharmacotherapy and EVL or not. If he was adherent to the therapy and still patient has recurrent bleeding, then we can go for tips. And if patient is not adherent to this medicine, then we will check for the compliance of the drugs, and or we'll do EVL. And if there is no recurrent bleeding, then we'll continue beta blocking agent and EVL until the varices are obliterated. And last is the primary prophylaxis. When we'll do primary prophylaxis, we'll do this therapy when before first bleeding, first evidence of the bleeding. And what are the indications of this primary prophylaxis? It will be done in patients who has first detected esophageal varices, but it is small with red color signs or child score B. In that case, we can go for primary prophylaxis. Or if patients have large esophageal varices of more than 5 mm diameter, in that case also we can go for primary prophylaxis. And this primary prophylaxis will be in a form of non-selective beta blocker agents, or we can do EVL. That's all. Thank you. Yeah.
I'm hoping that they must have done this. But few things they want to do at this practice.
First of all, I want to convey one message that ascites is not a sign of cirrhosis. It's a sign of portal hypertension. So usually, and second, ascites doesn't mean cirrhosis always for resident doctor. Okay, usually what happens, because you see the epidemiology, almost out of 100 ascites, 90 has a cirrhosis of liver. So what is in our mind? If ascites during the residency days, that this happens to us also. If ascites, usually patient has cirrhosis, but that is not the meaning. Okay, ascites just indicate portal hypertension, and you have to identify the cause of the portal hypertension, and one of the cause of portal hypertension is cirrhosis. So that is very important. Second, suppose in GI bleed, should you place a rice tube or not?
No.
Beta.
If you are just taking esophageal varices, you don't put rice tube, because if there is a varices and bleeding point is there is a fabric plug is there on the bleeding point, and if you put varices, there is risk of bleeding for the site. So,
what is the role of cold lavage? Usually patient comes with the GI bleed. Okay. Suppose it's we don't know, it's a varicose bleed or a ulcer bleed. So will you go for ice tube or will you give a cold lavage or not? Basic, most of the purpose during the residency days to put a ice tube is to just wash the stomach. Okay. So what is my opinion is you don't put a ice tube. Suppose you are in dilemma. Patient is hemodynamically unstable and you want to make it stable and still patient is means despite of all resuscitation patient remains unstable and you want to check the bleeding is ongoing or not. At that time gently you can push a place a rice tube, small diameter rice tube, just aspirate, and if there is a fresh blood despite of 6 hours, then there is a all possibility that the ongoing bleed is going on. You just remove the rice tube and go for endoscopy room even if the patient is hemodynamically unstable and ongoing bleed is suspected. Because unless and until you stop the bleed, this patient is never going to achieve a hemodynamic stability.
What is the management discussed in cirrhotic for hypertension bleed and non-cirrhotic for hypertension bleed? And when it comes to your first time,
You see, first time, if we are not very sure, we just put a endoscope and we see varices, there is no difference. Okay, but what is a more in next 2-3 days we used to see the changes in cirrhotic, means apart from the liver function test, the cirrhotics are the guys who used to tolerate a bleed very well.
very poor. Okay. Well, the other ESP, you are from management perspective, there is difference. No, nothing.
Beta blocker, there is
Beta blocker is endoscopic management. Beta blocker is all over. I mean, IT management, everything I am telling. So patient, so document is given that document DHCODR, so approach management now. ICU initial this is
You see, in EFPO, we are very happy that this patient is going to toilet simply, and our ICU threshold for admission is relatively low. Okay, first, secondary prophylaxis and use of beta blocker is questionable. Okay, though few studies are using it, even in NCP.
In the operation, they are using actual data from cirrhosis only. There is no study for NCP primary.
So that is a questionable. Beta blocker should be used or not. Okay. But this non-cirrhotic portal hypertension bleed are usually well tolerated. So ICU threshold should be low. Antibiotic use is a little bit judicious. And I don't think any other deliberation. Deliberation you can use in even non-cirrhotic. But what I feel that the vasodilatation, lengthening vasodilatation that happens in the cirrhotic, it is not in amount that is in the non-cirrhotic. So deliberation is also not very useful in the but if you are not sure, means if it is, you are very sure. If it is a non-cirrhotic bleed, just do endotherapy and conservative management. Consist from one sort of antibiotic. Otherwise, no deliberation, nothing like that. But if it is cirrhotic, then all these antibiotic deliberation and everything is needed. So, second thing, this is another very important point who is listening. Don't hurry for endoscopy. Try to make stabilize of the patient. Reason is, suppose patient is acutely bleed, means present in the GI bleed, having the hematemesis before 2 hours. You don't have enough blood reserve, and stomach is also full of blood. And 70% of the bleed, cirrhotic bleed, usually stops spontaneously after first episode. They give you a time. Okay, so don't be hurried. We have to go it in the night. No, this is not necessary. Better to make it stabilize. Give one shot of antibiotic, dressing. Okay, you do the baseline workup and ask blood test to reserve the blood. And in the morning, clean stomach. Endoscopy result will be better. So there is one study also when you do endoscopy in GIBs in the emergency. Second thing, these are all practical points. When you do it in the emergency, staff may be untrained, you may be tired. Okay, so these are the all practical points. Sometimes in this study they have calculated everything. So
results are poor when you do it in emergency basis. Unless and until patient remains hemodynamically unstable despite of 3-4 hours of resuscitation and you suspect the acute bleed is going on, which is not controlled despite of the all measures, then and then you should go for emergency endoscopy. Otherwise, it is okay.
And it could be less than 6 hours or less than 24 hours. In both the case, and if we are doing emergency endoscopy and in 24 hours we are doing endoscopy, mortality, hospital stay, both are almost same. So no need to do it within 6 hours. It can be done in definitely. No, primary. We are
Now, SB tube is what we call it is very difficult to. It's not available. Yeah, I have put during my residency days. Even I kept one for the sample. But SB tube, if somebody else, two things practical one. One patient has to be independent. Second, this tube you need to keep in the cold environment, refrigerator. So that it will become a little stiff. Then it will be easy to insert. Okay. And but it is not very available. And nowadays the endoscopy is available nearby each and everyone. And even if it is endoscopy is not available, 70-80% will stop spontaneously. And at least if you are 2 hours traveling time, usually patient reach the tertiary care center. So SB tube now is obsolete, almost obsolete. So I think અત્યારના રેસિડેન્ટો તો જોઈ પણ નહીં SB tube. Orange color tube or SB tube. There is another complication of SB tube apart from perforation, necrosis of alarm. Necrosis of alarm. So you just put pressure. So I have seen one patient who have kept on SB tube for 48 hours. Then make them stabilized and transfer to our institute. But by that time there is a severe necrosis. Okay, so we published that case also at that time. Then another important point is BRTO is for the gastric varices, not for esophageal varices. And just I want to, how will you select a shunt? Which shunt you want to do? Not in cirrhotic, but non-cirrhotic.
In non-cirrhotic, when clinical is available, it is always stimulation. PSS, proximal stimulation.
Reason is technical easy.
It is easiest thing, least complication. Exception are there when spleen is small, though there is age below, and rarely it happens in young patient, spleen is small, but and you want to preserve the spleen, then you want to slide the stimulation. This is the Mechra kind. This is the Dr. Mechra, side to side. DSR is not very easy because
And what is the advantage? Because spleen is small, so
you want to preserve the spleen in young patient. That is all. And there are studies that say that if you do extraction and decompress the spleen, then hypertension improves after some time. In 60-70% percentage, a good number of patients hypertension will improve.
but I think that type of shunt only can be.
Yes, practically no institution is doing. Very rarely it is done. Then when clinical is not available, then your option is a solution. Clinical is gone, so you bring SMV, supramesotic vein. Now supramesotic vein, your only option is photo vein. Sorry, vena. So you should take jugular to look at the solution. Third one is makeshift shunt. That's what we call is unconventional shunt. When you don't have much choice, then you will do if you whatsoever dialysis vehicle are available on both sides. We can do INDK version, we have done also here also. We can do even people have done splenoke version, they have got splenic vein to the dialysis and the other shunt. People have done adrenal and splenic vein shunt. These are unconventional shunt. In exceptional
One is
situation,
from the portal situation and one from the
in
just
one patient we have a good splenic one, but patient has action less kidney. So we can't do regular shunt. So we did INDK version. We have large antipathetic vein. So these are unconventional shunt. And in cirrhotic patient, only option, there are only two options. Practically, one is DSRS, just that as Dr. we divide the splenic vein from IV, so from SMV and do the stimulation, DSRS. Second is circulation, where you do portable shunt but of small diameter, 8 or 10 millimeter maximum.
And this shunt diameter is routine shunt.
The routine shunt is 12 14 millimeter, 12 millimeter 14 millimeter. It will be almost complete diversion of blood flow to liver. If you do side to side simple portable shunt, or you can do T, basically photograph.
Yeah.
When corridor is not very large, you can directly approach to gather and to the shunt, just like side to side anatomy. If corridor is large, you can put a small graph on the thing. And ideally, including patient should not put the graph more than 10 millimeters. Otherwise, patient will exert.
Nowadays,
No, this. I have seen only one DSR shunt in my career. No other patient.
Serotonic is
Very rarely. It is easily available. And this we don't tolerate the visual and surgery. So, in ESPO, we can do so many things. In MCPA, it is a very good paper to aid that prophylactic shunt, there is very absolutely then and there you should do shunt. In MCPA, that paper says that 48% patient has some form of complication after surgery, including asymptomatic but mild encephalopathy, abdominal nephritis, cirrhosis. So our threshold for shunt in ESPU is quite low, but for MCPA it is quite high. We don't do as far as possible, we don't do shunt unless it is absolutely. Everybody should read this paper. So this is part to me.
General question. At the all level, when the patient came with us and clinically we see that the patient has SIT, mild. And when we refer the patient to the radiologist for the radiological investigation, at that time, what is the normal total hypertension and when we consider the patient has a total hypertension high. So that is a normal figure. What is the normal figure?
So if you see the parameter in the USC, the short sign of the portal hypertension is development of collaterals. If collaterals are there, you are dealing with the portal hypertension. Okay? Significant portal hypertension. The first sign is the loss of respiratory variation in the portal pressure. So if the radiologist is very good, or if he is giving a detailed report, they will write that there is a loss of variation or respiratory variation of portal pressure is maintained. If it is maintained, you are not dealing with the portal. Third is portal vein diameter. If it is more than 11 millimeter, 13 millimeter, then you are dealing with the portal. And fourth is the portal.
Velocity. Reversal of flow.
Loss of variation, then direction of portal vein, and finally collateral.
And any changes we can see? Splenomegaly.
But splenomegaly, radiological splenomegaly is not as significant. Means you cannot correlate clinically.
This is contact. There is other evidence of cirrhosis and this splenomegaly is.
I'm telling you just a patient having severe enteritis or enteritis. Okay. And it's some amount of ascites and mild splenomegaly. So you can't say it's a
nodular liver, folded hypertrophy, fissure widening. These are some.
One very important protein USD is in ESPU, there is no portal flow. So you will always find a coarse liver, but it is not liver. They will always write coarse contextual liver, but that is still not liver. It is normal liver. But just because portal is blocked, there is no portal blood flow, it will look like coarse liver. So many times they might report it cirrhosis, it is not cirrhosis.
I think there is a portal.
Portal is only 10% should be the portal vein thrombosis.
Means, in short, nodular liver in radiology doesn't always mean cirrhosis.
There is no nodular liver, that is very important. But hypotension and under nodular current they want to go in it. Anyway, it is really not right. That is not the anything.
And very important, how will you monitor the effect of beta blocker? The resident doctor is how will you monitor the effect of beta blocker? Whether beta blocker is working properly. Okay, means that this is you must know. This is what the learning purpose of resident doctor. Suppose you start with the beta blocker. At what dose you are going to start? Okay, usually start with the low dose. Most of the we are using intra or something like that, 10 milligram BD, or if it is a long acting, then 20 milligram. This mic is muted. Okay, 20 milligram OD. Okay. Then how will you monitor? And up to what you will increase the dose? You tell me. You just tell me.
We'll check for the heart rate. If there is a decrease in heart rate from baseline up to 25%, then we can say that it is an adequate dose of beta blocker.
And I think there is some baseline less than 50 should not go.
Yeah, and then less than 40 or 55 should not go. If a patient is having a 60 heart rate, then in that case, it is not that applicable, like decrease 25% heart rate.
Any same for cardiovascular? Same for
And all beta blockers.
So that was non-selective, this is cardio-selective, that's non-selective.
Yeah, but in both we have to manage the heart rate or blood pressure.
Cardio-selective and non-cardio-selective both have ultimately act on the mark of person. As per the idea of the medicine, if the patient have a less than 55 heart rate and patient is on the beta blocker, it should be required to decrease or taper or stop the.
But I think this cutoff is 50 or
55.
55.
As per the medicine.
Up to 59.
Different guidelines. In the medicine, I see my patient who have a heart rate is more than 100, and I have when they started the beta blocker, and then suddenly next day patient came with me, if the heart rate is 55, it should be required to stop the beta blocker.
And what about the monometry? Many places in periphery you will see smoke is going on. So I think that practice should be discontinued. It is not useful nowadays.
Propranolol, nadolol, and carvedilol.
Propranolol, nadolol, and carvedilol. These three are the now approved drug for the prophylaxis of borderline.
And as per Bhavano 7 guideline, now carvedilol is the first line. Carvedilol is the first line. Till now, propranolol was the first.
Because there are the three benefits for use of the carvedilol. It works as a negative endoscopic effect, it works as a vasodilator, and also those patients who have a diabetes with the other disease, comorbid condition, carvedilol do not interfere with the metabolism of the anti-diabetic drug.
Initially, we used to use a carvedilol in patient as a respiratory problem, and we are able to use a non-selective beta blocker.
Those patients who have a diabetic with the other any disease and should be required any beta blocker, so first choice is the carvedilol.
And with hypertension, patient is having hypertension, in that case, carvedilol is the first.
But gastroenterology is not here, but my aim was to how they will select a patient for tips and how they will select a diameter for tips. And the H which is 20 up to 25%, but as per my knowledge, around 5 to 7% are irreversible. Rest all tips related H that initially occurs usually reverse in the 72 hours. That's not my knowledge, because 25% is too high. But I am not very sure. This I need to confirm, and you should also confirm that initial H usually revert in around 8 to 10% or something like that. They are remaining persistent H, and there is the biggest problem with the tips, and that's why interventional radiologists used to see that under stent rather than over stent. They are okay under diameter. They are okay if there is sometimes bleeding happens, but they are not okay. Even patient relatives are not okay if patient went into the permanent, goes into the permanent hepatic encephalopathy.
They will do balloon dilatation up to 8 mm and put stent of 10 mm. If required, then they will again yes. So that channel, that parenchyma, they will do dilatation to 8 mm. And they will put stent of 10 mm. If required, then they will put up to 10 mm.
Scan is scan, just for my
They tend to open for 10 millimeters because liver parenchyma is very soft. And this can
But in cirrhosis it will be hard. In cirrhosis the parenchyma will be hard.
So that's why the possibility. That's it. Okay, so we are concluding this session, and we will meet after 15 days. Thank you everybody.
Thank you.
Presentation